Hello and welcome to Unstress. My name is Dr. Ron Ehrlich. Before I start, I would like to acknowledge the traditional custodians of the land on which I am recording this podcast, the Gadigal people of the Eora Nation, and pay my respects to their elders, past, present, and emerging. Well, we've focused on sleep many times, and I don't actually think you can focus on it enough. It's like tapping a hoop along. You just need to keep tapping it along to make sure that it's rolling along and moving along nicely through life. As soon as you stop tapping that hoop, it drops, and so does your health with it, if sleep being that metaphor for the hoop. Well, today we are talking to one of Australia's leading experts in this field. It's Dr. Jim Papadopoulos. Jim is a paediatric, respiratory and sleep medicine physician. We cover a wide range of topics here. It's so good to catch up with Jim. I refer many patients to him, have done for over 10 or 15 years. He is quite literally brilliant, and I'm sure you're going to find him to be so as well. I hope you enjoyed this conversation I had with Dr. Jim Papadopoulos. Welcome to the podcast, Jim.
Hi, Ron. How are you going, mate?
I'm going very well. I've been looking forward to this discussion. We've been sending you patients for many years and always so impressed with your whole approach. And I've been looking forward to getting you on the program just to share you with all of our listeners. You know, the medical profession divides up specialties in so many different ways. It's sometimes surprising for patients to hear, and sometimes even surprising for medical practitioners themselves to hear that there are sleep medicine physicians, let alone paediatric respiratory and sleep medicine physicians. Can you tell us a little bit about your specialty?
Well, I was surprised that there were sleep specialists as well when I was training. I intended to be a general paediatrician. And when I got to the end and you got to choose like 3 years of electives, I thought, what don't I know much about? And one was developmental delays and disabilities, and I thought that would be important for a general paediatrician. And sleep medicine. At Sydney Children's, there was a fellowship available, and I decided to do that. And after I did the fellowship, I realised that I needed to change course and become like a general paediatrician of the night, because that's what sleep medicine is. Pediatric sleep medicine is how you fix things in the pediatric world, which are really important. Things like concentration, behaviour, learning, anxiety, all these the hard things that people try and address during the day with medication and other interventions. I realized that they could be, sorted and improved, and sometimes even cured by fixing the sleep problem, which was underlying and causing it. And that's the mentality which I think isn't out there enough yet. Even though the research into children and their sleep, like the first sort of papers were published in 1981 by Christian Gelemino, who sadly passed away a few years ago, into how sleep affects, concentration, behavior, learning in children, and the first sort of papers were published about obstructive sleep apnea and its effect and how treating it would then help all of these issues. And then it became obvious that anything that wrecked your sleep would have those consequences on you during the day. It didn't have to be obstructive sleep apnea. It could have been just not getting enough hours of sleep or getting a poor quality sleep for some other reason, reflux, allergies, asthma. So they're all general pediatric issues which affect your sleep, right? And then have consequences during the day. And people suddenly became aware, or at least in sleep medicine, became aware that it was the chicken and the egg question came up. Is the child anxious because of their sleep problem, or do they have a sleep problem because they're anxious? And it became more and more obvious that, for example, with anxiety, that it was the poor sleep which was causing the anxiety. Or do they have ADD and then don't sleep well because of their ADD? Or is it that they're not sleeping well and that's causing their ADD or contributing to it at least? And that's where it became obvious that sleep was actually the chicken and it was laying eggs during the day. and we needed analogy. So that's how I got interested in it. And it's not a new specialty. So, for example, it was back in the early 90s that the first sort of professors of pediatric sleep were sort of appointed, for example, in Boston and stuff. So it's actually, and the other really interesting thing is it's been since 2011, which is more than 10 years ago now, that it was recommended that sleep studies be done in children where you suspect obstructive sleep apnea as a standard, not as an option. And even that's lagging in terms of its implementation. It's 10 years later, and you know as well as I do that that's not the way things are done in most cases, partly because of availability of sleep medicine specialists and the sleep studies. Obviously, it'd be better if we could have more of these facilities around to actually cater for the huge need. But, you know, it's a really, if you think about how many people are affected by sleep disorders, and in children, like I can talk to the pediatric population, about 30% of children will have a clinical sleep disorder, 30%. And in the developmental delay and disability area, it rises to like 60%. And then if it's autism, for example, it's 80% of those kids are going to have sleep problems, right? So there's a huge need out there for people to recognize that sleep medicine is an important part of managing children's health, not just mental health, but also their physical health, because sleep disorders affect your growth. They can affect your heart and your lungs. They can affect all sorts of other things, your immune function, et cetera, et cetera, et cetera. Especially immune function lately has been important, hasn't it? So yeah, and it affects your, and then as I developed in my practice, I realized that orthodontic issues were linked to sleep as well. And that's where you've come in, and you've recognized that for many years now. And that's why you're serving your patients well by getting their sleep sorted, as well as their aesthetic and orthodontic and, you know, dental issues. You're helping them with their mental and physical health, not just short term, but long term as well. Because if you pick up these sleep disorders in kids, pick them up early, you save more IQ points. The earlier you pick them up, you get better orthodontic outcomes, you get better academic outcomes, you get better social outcomes. And then you end up with kids can outgrow their sleep disorders. Even sleep apnea is treatable and outgrowable. So they don't end up adults who snore and have an increased risk of stroke, high blood pressure, heart attacks, car accidents, you know, and all the family disruption and stuff that comes from having one or both parents who are always cranky, you know, or sleep deprived.
Well, I think a message that our listeners will have got over the many years we've had this podcast is that sleep is without a doubt the most important part of the day. I've heard it described as your built-in life support system, non-negotiable, hopefully. But you're looking at it not just from an ENT perspective, not just from a respiratory perspective, you're looking at it from a whole body perspective. And what sets people up for problems?
I think one of the main things I learned was that the physical sleep disorders are the main issue, and behavioral sleep disorders come as very often as baggage because people have got a physical sleep disorder. So the physical sleep disorder gets set up by your genetics. These things run in families. So you often find, say, for example, with obstructive sleep apnea, that one or both parents will snore. It's an especially strong gene if it's the mother who snores. Not so much the dad, but let's say if the mother's a snorer, it's like twice as likely that their kids are going to have sleep apnea than if she's not, for example. So genetic factors play a role. And it's the same with the gut issues. They're usually inherited as well. As you know, one or both parents or other extended family members will have, if the child has, say, reflux or irritable bowel, like gut issues disturbing their sleep, the parents will have that as well. Same with restless leg syndrome. Same with, you know, allergies and asthma, and same with a tendency to be, say, a late sleeper, late waker. All of these things can be hardwired in us and run in families, and the consequences then also seem to run in families. So you'll have the kids who have trouble with concentration, behavior, learning, anxiety, irritability, etc., insomnia, and the parents and siblings will also similarly have issues like that. It's because they have the same physical issues at night, disturbing sleep, leading to the same daytime consequences. So really what sets you up is that. And what the tragedy is that these sleep disorders are eminently treatable and eminently diagnosable. Like if you take one step back, you can figure out what's wrong with people and with kids especially, and you can figure it out early. Sleep studies are done down to 0 years of age. And the most important age group in terms of sleep apnea diagnosis actually is between 1 and 2 years of age, when they're at risk of having severe sleep apnea. So people often don't know that. They go, well, I have to wait till they're 5 years old to have a sleep study or something. And that's not true. Like, and the sooner you get it, the better. The sooner you figure out what the sleep disorder is, the better. Figuring out the sleep disorder is a really important thing, Ron. I think that's a real key to getting things sorted.
We're going to talk about the diagnosis and the treatment. I just come back to the genetics because it's often said that genes load the gun, but it's nutrition and environment that pulls the trigger. And in my observation, when I see someone come into my practice with all 32 of their teeth through and in perfect alignment, because we know the size and shape of the mouth affects the size and shape of the upper airway, it is so rare. I mean, literally, it would be less than 5 in 100. 95% of people do not have enough room for all of their teeth. So that's quite a shocking statistic. But in my clinical observation, I think that science may bear that out, but my clinical observation is that. So we start with narrow jaws, and of course, people within families are eating the same diet. So if something's upsetting the parents' digestive system, it's invariably going to upset the child. But coming back to diagnosis, and I'm often intrigued by sleep studies because I've done one myself. I've done it at home. I've been strapped up with electrodes all over my body and a little thing on my finger and around my chest and this and that. And my first reaction as a clinician who really recommends this to patients is how accurate. Well, tell us firstly what a sleep study is.
Okay, so
let's start from the beginning. I got ahead of myself.
I know I get this question all the time, and it's actually quite like in kids, it's easy. In adults, it might be a bit different because there are home sleep study options. But in children, you have to do sleep studies in labs. You can't do it any other way. Simply because you need to monitor them all night and go in and adjust things so that you get a very accurate result. An accurate result is accurate for someone having a sleep study in a lab in a child, right? So if you get 1,000 children having sleep studies in the lab, you can then develop statistics as to what sleep looks like in children having sleep studies in labs. We don't know how they sleep at home. So we know, for example, that in a lab, a child should have less than 1 obstruction per hour of sleep. More than 1 per hour is, very unlikely to be normal, less than 0.3% by looking at the statistics, that if you got more than 1 obstruction per hour, that you're actually still normal. So the statistics can be built, and they were built back in the 80s and 90s. So we've known for a long time that sleep studies are accurate in terms of diagnosing what the difference is between normal and abnormal sleep, because all the kids have the same procedure in a lab, right? So they all have the wires on them. They all have the nasal prongs. They all have the stretchy belts. And their sleep ends up looking like XYZ, right? Whereas at home, they'll sleep differently. But we don't measure it at home, so we don't know what normal is at home. Okay, right? But we do know what normal is in a lab. And in a lab, the studies have shown that you can do 5 nights in a row or 5 weeks in a row. You get the same results each night. Because looking at a whole night of sleep with lots of sleep cycles in it, and that statistically becomes very robust. It's like doing a study on, and having 5,000 participants instead of having just 5. You're going to get statistics that mean something and that are robust. And, for example, arousals per hour should be less than 10 per hour in a sleep study. Restless leg, periodic limb movements per hour should be less than 5 per hour. The percentage of dream sleep should be between 20 and 25 when they reach that sort of age group above 8 or 9. So, and it's more the younger. We know all of the statistics, and then we can interpret the results of a sleep study done in a lab, done right, done according to the rules by experienced people, and then interpreted by experienced people. Then you get results which mean something.
So let's start with what is a normal or an ideal night's sleep. And of course, the time varies with age. In terms of requirements. Can you just give us a sort of a 101? What is an ideal? You mentioned a few things there, but what's an ideal night sleep? What's a good night's sleep?
Yeah, so you expect in terms of the hours of sleep, that's what a lot of people ask about, but that can vary. If you're over sort of 16 to 18, you need about 8 hours of sleep, or 8 or 9, right? Between sort of 12 and 16 to 18 adulthood, you need about 9 hours of sleep. Surprisingly enough, a lot of 15 and 14-year-olds are not getting 9 hours of sleep. Between the ages of sort of 4, 5 and 12, that sort of childhood period, you need about 10 hours of sleep. And under that, when you're napping, you might get an extra half hour up until, between the ages of sort of 4 and 5. And then you shouldn't need any naps during the day after age 5. And then we go down into the infant, sort of the toddler groups and the infants, and they need sort of 11 hours. And then there's 12. And then in the under 1-year-olds, there's a whole range. Like it's too gritty to really go into here, but everyone knows that the newborn infant, for example, will sleep and wake according to their feeding cycles. After about 3 months of age, they tend to sleep through the night, or start to sleep through the night, after 12 weeks. And then they might have, 12 hours of sleep at night and another 2 or 3 during the day with naps and stuff. So it becomes, that's it as a general rule. But if you're looking at a child, maybe orthodontic age group or whatever, the pediatric age group, they should fall asleep within half an hour. They should be able to fall asleep on their own without a parent there. They should stay asleep, maybe wake once for toileting, and then in the morning when they wake, they should wake on their own and look refreshed in the mornings. They shouldn't be hyperactive in the mornings. They shouldn't be cranky in the mornings. During the day, they should, have normal sort of concentration and behavior, and that varies with age as well. Like you don't expect a 2-year-old to act the same way as a 5 or 6-year-old, but if they've got age appropriate behavior, then that's a good sign that they're getting a decent sleep. Learning issues and stuff can be a hallmark that your child's not sleeping well, even if they're sleeping all night. If they have issues with, say, concentration or irritability, especially in the afternoons or when they wake up. Trouble with language-related things is common in sleep disorders, and I'm not sure why that is, but it seems to be that developing language really needs good sleep, and it can be pronunciation difficulties as well, because maybe the way that your jaws are forming and you're using your tongue and the way that you chew stuff and interferes with how you can pronounce things, and then there are tongue ties and lip tie and all of that can interfere with pronunciation, which are also linked to sleep disorders, either respiratory or other. And the other thing that's really important to point out is that a lot of these kids have issues with feeding, with eating and stuff during the day, restricted diets, avoiding chewy foods, preferring milk and dairy, being thirsty a lot. All these can be hallmarks that your child's actually got reflux, and that reflux really mimics obstructive sleep apnea, and it can present with snoring and sleep difficulties the same way as sleep apnea does. And in fact, I know I've gone off on a tangent, but
I've already got a question for you on that tangent.
Yeah, because I think that we need to get into that.
Yeah.
If you do, so around about 10% of children snore. Out of the 30% have got sleep difficulties, 10% are snorers. And snoring can be either vibratory or non-vibratory. But non-vibratory snoring is actually more common than vibratory snoring. And that means heavy breathing in sleep and mouth breathing. So that sort of thing is snoring in children. They should be quiet when they sleep, especially and often you ask the question, does your child snore? And the parent says, no, they don't. And you say, well, can you tell if they're asleep by their breathing? They say, yeah, we can hear them at the door.
Right.
That's quite loud snoring. Yeah. And so of the 10% who snore, 1/3 of them will have obstructive sleep apnea, snoring with sleep difficulties I'm talking about. The other 7 don't, but they're still snoring and having sleep difficulties. So what's the rest? And often, a lot of the time we do the sleep studies on kids who everyone thinks for sure they've got obstructive sleep apnea because they've got big tonsils, they're snoring, they've noticed there are pauses in the breathing when they sleep, nasal congestion all the time, they're cranky, they wake up in the second half of the night, or sometimes they sleep through the night but look exhausted the next day. We do the sleep study and there's no obstructive sleep apnea, but there are a lot of arousals, and it's a very restless sort of sleep. And we can pick that up. Sometimes there are periodic limb movements in sleep as well. Anyway, and those kids often have the gut issues disturbing sleep, because reflux gives you nasal congestion. Reflux gives you snoring, especially if and reflux makes sleep apnea worse too. They go together, and sleep apnea makes reflux worse. So it becomes a bit of a mixed pot. And that's why you need a good sleep study to work out which of these things are affecting you, so you don't get your tonsils out for nothing. Or, taking out your tonsils and adenoids usually is very good treatment for snoring, right? So it'll make you breathe quietly at night. But then afterwards, did your sleep improve or not? Because you can help snoring, but still have sleep difficulties afterwards. And sometimes, and I think that could be even 2/3 of the time, according to the statistics. Yes, the sleep apnea component may have been sorted, but you also had a gut issue. But other times it's all gut issue. My 3-year-old, when he was 3, he's 11 now, had big tonsils, snoring, a family history of sleep apnea. 2 of his siblings had sleep apnea. We did his study, and he was swallowing and gulping in his sleep. He was stopping breathing because the acid was coming up, and when acid comes up, there's a reflex we have to stop breathing. So you can actually see pauses and gasping in kids with reflux. So it's not diagnostic of sleep apnea, of obstructive sleep apnea, to have snoring, pauses, gasping, big tonsils. It's not diagnostic.
Yep.
And they can have the narrow palates, right? And the overjets, Ron, which you know about, right?
Yeah.
And you think, oh, straight away, that's sleep disordered breathing. But if you've got nasal congestion for any reason, it gives you that orthodontic outcome. It doesn't have to be obstructive sleep apnea. It can easily be, and in fact, more likely is something like just an allergy in your nose or reflux, according to the statistics. And that's where I get excited because I go, wow, you can do so much good by figuring these kids out before you do any operations. And that's why they made the recommendations in 2011 that you study children who are suspected of obstructive sleep apnea. The answer is not take out tonsils and adenoids straight away. The answer is do a sleep study first.
Yes. I've often heard, I actually use the analogy that taking tonsils out is something like driving along in a car and a hazard warning light comes on your dashboard and you actually remove the globe in the dashboard to solve the problem. You're really not.
Analogy,
and actually, we did a podcast.
Not always, okay. Not always.
No, I know. And sometimes it can really make a huge difference. Yeah. But I did a podcast with a gastroenterologist, Dr. Pran Yoganathan, and Pran said something that really, I'd never thought of it. And he said that he feels like a lot of reflux is a function of diaphragmatic sarcopenia, meaning underdeveloped diaphragm, which shallow breathing, not using your diaphragm from a very early age, could create an underdeveloped diaphragm, not to mention some of the crappy food we're eating, or people are eating. Tell me why, another thing we focus on is mouth breathing versus nasal breathing, and people kind of, that's interesting. Why are noses so important?
You're meant to breathe through your nose to help your breathing function properly. And it's not just the filter, but it's also a humidifier so that the air that gets down into your lungs is appropriate for the environment down there. You don't want to, but this is just during the day. It protects you to breathe through your nose. But if you're a mouth breather at night, then it potentiates, it's both a chicken and an egg. It causes problems, but it also is the result of problems. So it can act as a red flag, suggesting that you've got issues which are not related to your airway, which are affecting your health in a sense. So that's the importance of the mouth breathing side of things. It's interesting how many dentists and orthodontists are aware of this stuff now, and then look into what the other medical issues could be which are leading to the mouth breathing and the bruxing and the dental enamel erosion. And the not just about malalignment of teeth or not having a proper bite, people ending up with headaches because they're grinding their teeth all night, or because they're refluxing and they're re-swallowing, or they're grinding their teeth because they've got periodic limb movement disorder, restless legs, and their jaw muscles are affected just like their legs are crunching through the night. Their jaws are crunching through the night, or obstructive sleep apnea is linked to that as well, to bruxing. Anyway, so bruxing and mouth breathing tend to go together, I think. And when you see the wear on the teeth from bruxing and you see the wear on the top, on the molars, sometimes you also see enamel erosion on the sides, where the dentine is coming through and you can see the yellow underneath the white.
Yep.
Well, that's a red flag for acid getting up into the back of your teeth, especially at night when you sleep and you're lying down flat, and burning away the enamel. How many kids have you seen, or your colleagues, where you cap the teeth, the molars, because there's enamel erosion, and then you find out, okay, they're mouth breathers, and you say, it's because they're mouth breathing that the enamel's eroding. It kind of probably is something else as well, or instead of that, that you've got acid reflux, and you've got silent reflux, so the kids are not complaining, and they're not getting the burping, the hiccups, the bad breath, the stomach pains, the vomit burps during the day, but they've just got a poor sleep at night, ending up with a nasal congestion, mouth breathing, and the acid's coming up and washing the back of their teeth. And then they go off and they have their adenoids out, they have their turbinates shaved back, they have all sorts of ENT procedures to try and fix the nasal congestion, but it doesn't work. And they continue to be mouth breathers in sleep. And they have orofacial myology interventions, they have their lip, their tongue ties and stuff divided, and they're still mouth breathing when they sleep. And you go, well, what's going on now? Because you've missed the elephant in the room, which was that they have silent reflux. And silent reflux is actually 40% of reflux is silent, only affects your sleep, doesn't affect you during the day.
Yes. You'd be interested to know, Jim, we're doing a whole program on laryngology, how do I pronounce that? With talking about that very subject, silent reflux, because it is a huge and undiagnosed.
And it affects your diet, Ron. You know how you think about your diet. I want to sort of do that sort of chicken and egg thing with you, flipping it around a little bit.
Mm-hmm.
Okay. If you're a kid, if you're a baby, right, and you've got reflux and you're sucking on milk all the time because you need to treat your acid reflux with something, because no one's recognizing reflux as an issue in babies. They're not giving them any treatment. They need to breastfeed frequently. Every half hour, they need something to suck on. And they end up co-sleeping with their parents, and they're driving their parents nuts because they all have to be held upright all the time and stuff. Otherwise, they scream every time they're put down. When they move on to solids, they don't like solids. They don't like chewy foods. They don't want to chew. And if you don't chew, you don't develop your jaws, right? And you see that as underdeveloped jaws, but their diet becomes a mushy diet or a bland diet. They don't have meat in their diets because things that are chewy, or if they have meat, it's got to be mince, or it's got to be sausages, or it's got to be chicken nuggets. It's got to be something soft that goes down easily, because swallowing through a burnt food pipe can be painful, or they do it once, something gets stuck, and they go, I'm never touching that food again. At the age of sort of 2 or 3. And they become, children who never use their jaws and don't chew, and they have just sort of processed foods all the time, and that's not good for their health. But it's also, is it the chicken or the egg? Their diets that are poor, and you try and fix their diets, but the child, if you haven't fixed their reflux stuff, right, they still want to they don't want to eat the new food that you're telling them this is what's good for you, because it's not comfortable for them to eat it, and they don't like it. They still prefer their old diet. And you're trying to change someone's habits, you're pushing it uphill. Whereas if all of a sudden, like if we've diagnosed the silent reflux, we treat the kids with the anti-reflux regime that we have, they start to eat meat on their own. They start to eat chewy foods on their own. They stop having all of the milk and dairy and all the rest of it that they're addicted to. They try new foods. They try textured foods. And this is not just for kids who are normal in the sense that but it also in kids who've got sensory processing disorders. So the autistic related spectrum kids start to eat a variety of foods instead of just restricted, just having white bread all the time, and that changing their diet. How good is that? Just from a nutrition and general point of view, just because you got down to the cause, which they inherited from their parents, which is the gut issues that then determines what their preferred diet's going to be. And their preferred diet, we think, we change the diet. Let's change the diet and we'll fix everything. But you're not. You haven't fixed the problem yet. You're offering Panadol for a toothache. You haven't sorted out what's wrong with the tooth. Same with melatonin.
Same with melatonin. Now, hang on, you just threw that in. We're going to come back to that one, Jim. But I just wanted to come back to this reflux for a young child that's breastfeeding, because having had now 4 grandchildren and watched it all happen, I realised that what's often overlooked is a young baby is being breastfed and may have colic. Is that the reflux? Is that
Could
colic?
be, yeah.
But
so common,
yeah. But what's not addressed is the mother's diet.
Yeah,
that there is something within the mother's diet that is causing this.
100%. And the first thing you do when you're trying to treat infant reflux is not put them on medication, but you eliminate cow's milk from the mother's diet if they're breastfeeding.
Right.
You avoid the cow's milk protein. That's the most common sort of allergen that affects their sleep. And all of a sudden, a lot of that's in the recommendations from 2018, International Society of Gastroenterology. Like they did an article, the European Society and the the American Society got together and did, how do you approach reflux in infants and children? And in infancy, it's definitely not medication. It's diet in the mother and avoiding the cow's milk issues. First up, that's the first step that you do, and because that helps so many of these kids. And it's not forever. Obviously, they can start to tolerate cow's milk and things especially after age 12 months and stuff. Our bodies change to be able to tolerate these sort of allergens and irritants better. But not always. But that's a really important thing. Sorry. Yeah.
But some of the people that we see coming through who probably have just been seen by their GP with a young kid, an infant with reflux, are on SOMAC or some protein pump inhibitor or something like that.
No, in infancy you don't do that first. When they're over 18 months of age.
Okay.
When they're over 18 months of age, if they've still got reflux. It's the sort of reflux that needs a pediatric gastroenterologist, because that's the sort of reflux. That's not the usual sort of physiological reflux and irritant related stuff and things that you outgrow. If you've still got problems after 18 months of age, that could be a whole range of issues that might need further investigation and treatment, because they can, worst case scenarios, you can end up with permanent scarring, for example, of your esophagus, of your food pipe, if you have untreated conditions like just reflux, or it could be even allergic reflux, the eosinophilic esophagitis. And that often presents with snoring and sleep difficulties. Right? And these kids very often end up having a sleep study after they've had their tonsils and adenoids out and hasn't worked. Whereas, I'd contend that it's good to get things do the diagnostic study first and then work out what you're dealing with. I mean, who would go and have their a headache treated with brain surgery before having an MRI scan to see is there a tumor or not? That's the thing. Anyway.
And what does our children's, another topic, you'll love this, Jim, another topic that we sometimes, or phrase that I use is, what does your poo say about you? Because every day we get a report card from our body, and, and it's one worth looking at. It's cheap and it's very personalised medicine. What do poos tell us about a kid's digestive system?
Okay, I'll start at the beginning. So with the infants who've got the cow's milk protein allergies, like the obvious ones, they often have mucousy bowel motions or may even have blood in their bowel motion, but not necessarily. They could still have sort of normal infant poos and have significant benefit from eliminating the cow's milk from the mother's diet if the child's breastfed, or going on a special formula, which is pre-digested, to make it easier for them to deal with. So in the older age group where you're looking at poos in nappies, toddlers and things, the poo, it shouldn't be dry. It shouldn't be a poo which sort of is like a pad which falls off the nappy. That's sort of too firm, and that could be an indication that you're dealing with a degree of constipation. But constipation is tricky because sometimes the poo is just normal, but there's lots of it, and so a lot of kids are constipated, or let's not call it constipation, let's call it fecal loading, and do several poos a day. But it's like the M5 tunnel. Sometimes it's full of cars and the cars are coming out all the time. It's full of cars, it's loaded. And other times there are cars coming intermittently and it's not loaded inside. It's the fecal loading which is the issue, because when the colon is stretched out, and it is in families who are predisposed to these issues, it sends a signal back to the stomach to tell it to slow down its emptying. And so you end up with more reflux at the top if your colon is stretched out. And it could be stretched out by hard poo, could be stretched out by soft poo. If there's the fecal loading issue though, and you can feel it in kids' tummies, you can feel where if it is fecal loading or not. We don't do x-rays to check for that. But in general, like if a child doesn't have a sleep problem and they're doing a poo every 1 to 2 days and it's sort of like comes out like a sausage and stuff, and it's a normal, they've got the Bristol stool chart, then there's nothing to worry about. But if there's a sleep disorder, if there's trouble sleeping, we focus a lot more on the poos, and we think, especially if they're diagnosed with reflux at the top end, the approach needs to include getting the poo to be as soft as porridge so that the bowel can unstretch over time and then it allows the stomach to start to flow faster. And that's how you can cure the reflux in older kids 95% of the time. Okay. And you can change diets and things as well. But it's important not to increase fiber too much. So, because if you give kids fiber supplements, you've got this issue. The fiber, the psyllium, for example, in Metamucil and in all of that, is like sawdust. And when you add water to sawdust, it expands. So you give someone psyllium when they're in that situation, and it expands the gut more instead of decompressing it. And you think you're doing something good, but you end up with more stomach pains and all the rest of it. And that's why Osmolax is used in that specific situation. And now remember, I'm not talking about a normal kid, a kid who doesn't have sleep problems.
Yeah.
Let them have Metamucil or lots of fiber in their diet and all the rest of it. And we should have fruit, and we should have the normal amounts of vegetables, even if we've got gut issues. Okay. And the more the better. But at the same time, if you're trying to get over that speed hump and treat someone, it needs to be under the care of an experienced gastroenterologist. And it needs to be, with some Osmolax on board as well. As you talked about the SOMAC. The SOMAC is really useful. My 3-year-old was cured. You know how I told you how he was diagnosed?
Yep.
Well, he was on SOMAC and Osmolax it was about 6 months.
Right.
And then he came off it and he was fine after that.
Okay.
And then it came back again when he was 5. He started snoring again. And I thought, okay, this time for sure he's got sleep apnea. We did a second sleep study and it was all the same issues again.
Right.
Okay. And we treated him again and it went away. And he's been fine ever since. So this is the thing. People are predisposed to it by their genetics. They have the sluggish bowel issues. And it shows up in one family member as irritable bowel, another person as lactose intolerance, another person has severe reflux disease, another person has got sinus problems and they've had multiple operations and their nose just doesn't get cleared up, never does. It's been reamed out several times and they still have sinus problems, headaches, bruxing and stuff. And then they might have bad breath as well. And and they've been diagnosed with allergy because their skin prick test says they've got dust mite allergy. Well, you can have dust mite allergy and reflux at the same time, right? But if you treat the allergies and you don't respond, then it's a non-allergic rhinitis that you've got. So non-allergic rhinitis is reflux until proven otherwise.
Yeah. Gee, Jim, I love this.
For me, it's logical.
Yeah, this focus on, dare I call it, the whole body. Wow, what an approach. I mean, I know it's obvious, but it's not often practiced or not practiced often enough.
Maybe that's it.
Yeah.
People might not be aware. Like I've had the benefit, right, Ron, of working with the hardest kids. With my disability clinic, I started it in 2003, and this is with autistic kids and Down syndrome and all the rest of it, right? And I had to make it work. It wasn't good enough to just do this. Okay, you've done a sleep study. It doesn't show sleep apnea. Sorry, you've got ADD. Go and get your Ritalin.
Yeah.
Because these were kids who weren't sleeping. I had to do something to help. And lucky I was blessed by being involved with lots of colleagues who come from other disciplines and talking with them and working with them and then picking up the clues that, okay, in the gastroenterology field, this is what's relevant to sleep. In the dental field, this is relevant to sleep. In the orofacial myologist, this is what's relevant to sleep, and putting it all together. And then over time, finding solutions for these kids. And I know this is a bit off track with the gut issues, but for example, in Down syndrome, right, 80% of those kids have got sleep apnea in Down syndrome. When you take out their tonsils and adenoids, the chance of cure is like a lot less than in the general population. Most of them still have some sleep apnea afterwards. And in many cases, okay, it's accepted as, okay, that's the best we can do. Because these kids, there's no way that we can treat them with orthodontics and we can't treat them with CPAP. There's no way they would tolerate that. And it's tried, but I couldn't do that. So I persevered, and I've treated so many kids with Down syndrome who've still got sleep apnea with CPAP, and they take, like, the way that we do it, the approach, it's logical and it's stepwise and it's a little bit pedantic, but it gets there at the end. Kids with autism with CPAP, kids with Down syndrome with CPAP, and that makes a huge difference to their lives. And now moving on, I've graduated them to the adult services. A lot of my kids who arrived as children now become adults who wear CPAP with Down syndrome. And the thing you need to know about Down syndrome is the main cause of death, like early death in Down syndrome people in their late 20s, early 30s, is right heart failure. And the right heart failure comes from untreated severe obstructive sleep apnea over many years.
Mm.
They don't have to go there.
Mm. And compliance, Jim, for these challenging kids?
10 hours a night, 9 hours, 10 hours a night.
They comply.
Well, you got to get the right mask. You got to get the right pressure. So they need a CPAP titration. You can't just put them on automatic machines. And you can't put them on an automatic machine for one night or 2 nights and then do a titration. They've got to get used to wearing it at home for a while before you bring them in for their titrations. You got to do the titration properly. You know, I don't know if you know this, but St. George Private is the only sort of private lab which is accredited for CPAP studies.
Right, I didn't know that.
By
Okay.
NADA.
Yep.
The other place you get CPAP studies is in the public hospitals, of course, right? So, but because as I said, I threw myself in the deep end. I got the chance to work with lots of patients in this situation, and work out the nitty gritty of how you do this. And with the dental side of things, you know, I worked with Professor Darren in he's the professor of orthodontics, Sydney Uni, Sydney Dental Hospital, many years, and I had my adult colleague, Dr. Andrew Ng, special interest in dental sort of sleep medicine. Yep. He did his PhD back ages ago in the mandibular advancement splints and stuff and how they affect adult sleep apnea. Anyway, we did a clinic at the dental hospital, picking up all the patients coming through their chairs, and we would do sleep studies on them, and 90% of them didn't have sleep apnea, even though they had all the orthodontic changes. They were all gut issues. But the ones who did still have sleep apnea and needed the orthodontic work, we found that when you put the plates in to do their maxillary expansions, their sleep apnea would get worse while the plates were in. Or if they were on CPAP already, the CPAP pressure need would go up while the plates were in. It's only at the end, after the course of treatment, when you take the plates out and you stop the CPAP, that you can look for whether they've been cured or not. It's about 30% chance of cure after orthodontic work for sleep apnea in normal people and stuff. But, you know, we learn from that, and the professor knows, and all of the orthodontic students, the master students who go through there, because we were giving them lectures all the way through, learned that, you know, if you're going to do an expander on someone who's got sleep apnea, they have to be covered by CPAP at the same time. So they don't have sleep apnea for the 9 months that they're on these expanders, the rapid maxillary expand. And it's important to have a fixed appliance if you're going to do CPAP, because you've got to use a full face mask for them. Yeah. If you have a removable appliance, it's a choking hazard with the CPAP, right? So these are all the little things that came up out of all the years that I've been working in the dental with the gastroenterologists, you know, and all that with the disability stuff. And when you say, oh, it sounds like you approach things in a holistic way, it's because I had to. Otherwise, I wasn't getting any results for any of my kids. They weren't sleeping better after they come and had their sleep studies and had their tonsils and adenoids out, and got the elephant out of the room, which was the obstructive sleep apnea, but left the rhinoceros and the monkeys running around still, you know? Yeah. You got to get all of them out.
Now, you've mentioned a few special needs people, and I remember years ago when we spoke on a podcast many, many years ago, you once said something like ADHD. ADHD is a pretty big problem. I think I've heard the statistic 1 in 10 kids are diagnosed. Is that true?
6%. The population rate is 6% of ADHD. 6%.
But
in sleep apnea, in one study, 48% of the kids who had sleep apnea had been diagnosed with ADHD and treated with stimulant medication. Thank you very much.
I remember you once saying that to me, and that's a huge statistic. I mean, that's a big aha moment. Yeah. I talk about undiagnosed, going to the cause of the problems rather than just treating them symptomatically. What about autism? You mentioned 80% of kids with autism
have got sleep problems. So that could be trouble falling asleep, trouble staying asleep, wanting to co-sleep, acting sleep deprived during the day. Now, the thing with autism, which is really special, is that they've got these sensory processing issues. Okay, so they're more sensitive than everybody else is to things like changes in their routine, for example. So the psychological things that they're more sensitive to, but also, you know, bright lights, smells, sounds, and internal feeling, internal sensations. Sensation of allergy in someone with autism is 10 times worse than someone who doesn't have autism. Sensation of reflux, sensation of constipation, sensation of restless legs. It wrecks your sleep so much more than it does, you know, your sibling who doesn't have an autistic spectrum disorder. And so they sleep like the princess and the pea, slight thing of a bit of discomfort, and it wrecks their sleep. So for me to help autistic kids sleep better, I've got to make them super comfortable when they sleep. So if they've got allergies, I need to treat them. If they've got sleep apnea, I need to treat it. If they've got the reflux, if they've got the constipation, if they've got the, all of those things, we need to treat them. We need to treat them effectively. And all of a sudden, they sleep better. And then, because sleep disorders make you more sensory, if you don't sleep well, you're more irritable the next day. But not just psychologically, but everything bothers you. Loud noises, bright lights, internal and external sensations, right?
Yeah.
And anxiety levels go up when you don't sleep well.
Yeah.
So you reduce all of that, and all of a sudden they're sleeping better at night, and during the day they're less inattentive, irritable, and anxious. And so they can start to learn, they can start to focus better during the day on what they're supposed to learn. And then at night when they sleep, that can be consolidated from short-term memory into long-term memory and translate into skills. Building skills only happens at night. You can teach someone how to do something during the day and they might get it. They go to sleep. If they don't sleep well, the next day they don't learn. They haven't got that skill. It doesn't translate into a longer-term benefit for their language or for their reading or for their social skills and stuff. So they start to learn. And then the speech therapists start to make progress. And then the occupational therapists start to make progress. And the teachers start to make progress. And they go, wow, we need to look out for kids like this who've got sleep problems and refer them for their sleep assessments and sleep treatment so that we can start to make progress with our programs, which the NDIS is funding. And they get zero bang for their buck if the kid's sleep deprived. It comes back. It's a real integral part of trying to address developmental delays, disabilities. But it's not just, we mustn't forget that there are highly functioning kids out there, right, who are top of the class, but who are irritable and anxious. Their concentration might be better than mine, like fantastic, and they might be getting top marks and everything, but socially they're a bit isolated. They might be a bit withdrawn, a bit anxious, a bit irritable, clingy, and they've got a sleep disorder too. But because they've got they've been blessed with higher abilities in certain areas, it masks it. And they never thought of us having a possible sleep disorder, but they're taken to, psychologists and things for help with their anxiety or their phobias or their withdrawal and stuff, or sometimes not even recognize the stuff. And they go, no, he's just, that's their personality, doing well at school. So it doesn't matter. Don't worry about it.
You see kids of all ages. When you see, what are the warning signs or the alarm bells go off for you when an infant or a toddler, or say an infant, is brought in and you kind of think, wow, you must have seen it many times, that this is developing into autism, or this could be developing into autism. How early can you call it?
I don't. I never call it, Ron. Sorry. Yeah.
No,
that's the answer to that question.
Yeah. But are there some warning signs that, are all those things like poor sleep, difficulty in eating, fussy, all these kind of things give us some warnings?
So the way that we're trained as pediatricians is to say, okay, there are warning signs, but until you do the interventions, you don't know if they're reversible or not. So we never call it, and I'm not going to go there. I'm going to say that if you see these signs, then you should look for help.
Yep.
And then with intervention, with diagnosing it and treating it, you can get rid of all of that. It can just go away. And that's not autism, right? Or an autistic spectrum disorder. It's just you've inherited a personality which might be a little bit more sensitive. And because you had something else going on in your life, which was wrecking your sleep, or you have difficulties with, between the parents or with siblings or financial situations and stuff, you're more stressed, and it shows up as, when people are more stressed, they act autistic, don't they? That's what your podcast is about. Okay, relieving stress helps people's mental health, and you don't want to diagnose or label any children at all until you've had a chance to help them and intervene. And it's got to be a holistic approach. And it's got to include sleep. I know I'm pushing that a lot today, but
no, you can't push it often enough in this program.
But I think you got to address the sleep when you've got issues with that. Yeah.
Jim, you mentioned restless legs a few times, and as a thing, and I'm guessing it's almost self-explanatory, isn't it? You're lying in bed and there's limb movement, a lot of excessive limb movement. Is that what restless legs is, or is that too obvious?
No, man. Okay, look, that's what everyone thinks it is.
Okay.
But when we do the sleep studies and you see the restless legs happening, they're usually small movements, little contractions of the tibia, and it can be in your arms. And they're like little squeezes, and it can be in your jaw as well. Usually it's all of it, but we have the sensor on the biggest muscle that's most usually affected, the tibialis anterior in your leg, at the front of your leg. And it picks up these movements. And I show people the videos of restless legs, and they go, "What? I didn't see anything." And I go, "Well, that's restless legs. What you're describing, the tossing and turning, the big movements and all the rest of it, is usually not restless legs. Big movements in sleep where the child's obviously tossing the sheets and all the rest of it, it can have a component of restless legs, but usually it's a discomfort due to obstructive sleep apnea, waking up and moving, or reflux or bowel constipation and stuff that are making you uncomfortable in your sleep and tossing and turning and causing arousals. So if there's lots of tossing and turning, could be restless legs, but it's usually not what we see when we see restless legs on sleep studies.
And what about night terrors or sleepwalking?
This is interesting, and I like it. I like that you brought that up, because one of the first things that taught me how important gut health is with those issues was a child who came in and was having night terrors every single night, waking up. Usually it's a couple of hours after you go to sleep, before midnight, as you go into your deep sleep. It's not dream sleep, and you come partially awake, and your brain is not switched on. The thinking part of your brain is not switched on. Just your instinct part of your brain is switched on, which the only instincts you have at that point are fight or flight. So you scream or you fight, and if someone stimulates you or tries to calm you down, you react and it gets worse, and you escalate. Same with sleepwalking. Sleepwalking happens to older age range group of kids, and night terrors are the younger age group. So maybe 2 to 4 for night terrors, and maybe 2 to 6, 2 to 5, and then after that it becomes sleepwalking in the same person. What they are is a symptom of sleep deprivation. They're not because you've been abused or because you've been traumatized. That causes nightmares, which are dreams that you remember the next day, which happen in the second part of the night. Night terrors and sleepwalking is because you're overtired. So there's usually an underlying sleep disorder which is making you overtired, unless you're someone who just sleeps 3 hours a night and all the time, and you sleep deprived because of that, and you get your night terrors. So what I found, like this kid had a sleep study, and it showed just some restlessness in sleep, and they had fecal loading where they were doing a very large but soft bowel motion every day. Twice a day it was, actually. And when you felt their tummy, it was full. So I treated them with the Osmolax, and within a week they stopped having night terrors. It was just it was all from the lower end. The top end, there were no sort of symptoms of reflux and stuff. So I just treated them with the constipation treatment that time, and it worked brilliantly. And I'm going, how many kids do we see as well through the diagnostic clinic, through the disability clinic? It's almost taken for granted that a child with a disability or whatever is constipated. Oh, yeah, they go every 2 or 3 days and they're like rocks, or they're soiling their pants, and they think that that's not. People think that that's normal and acceptable, but usually soiling of the pants is overflow of soft poo around the hard cannonball, which is in your rectum, and they soil their pants by having accidents all the time. And you treat that constipation, and it goes away, and their sleep improves, and everyone has now got clean undies and stuff, and everyone's happy. Anyway, but back to the sleepwalking and night terrors. It can be because of sleep apnea, undiagnosed, can be undiagnosed reflux, can be undiagnosed restless legs, it can be undiagnosed anything else. I saw one kid, and I often see this, where if they've got dust mite allergy, they're snoring and they're having sleep difficulties, and they could have sleepwalking and night terrors as well. You do their sleep study, and it comes back normal, right? Not restless, and not snoring, and not having sleep apnea, because in the sleep lab, it's free of dust mites. You treat those kids with Nasonex, nasal sprays, and their sleepwalking, night terrors, sleep problems go away or get better, like a lot better. A lot of them have got other allergies as well, or need help from a pediatric allergist if they need desensitization and all the rest of it. But you can nail these diagnoses by what's shown up on the sleep studies.
But listen, one other one I wanted to ask you about was bedwetting, because I mean, kids in nappies, yes, they wet their bed, but when it's 5, 6, 9, 10, 12-year-old is still wetting the bed.
Okay.
Talk to us about bedwetting, enuresis.
Okay. So enuresis often runs in families, right? It needs to be treated when they're over age 6 or 7, right? The causes of it, the first thing that they ask about when you go to the enuresis clinic is, are you constipated? Because a big poo in the rectum means there's no room for the bladder. And so overnight, your bladder has problems. That's the first thing that people in enuresis clinic will treat, your constipation first. Sleep apnea is linked to bedwetting as well. So if you got sleep apnea and you treat it, 80% of those kids get better with their bedwetting. 50% of them, it'll go away on it altogether if you treat your sleep apnea. And so if you see a child who's got bedwetting and is snoring, mouth breathing, got sleep difficulties, etc., think about it as, don't put them on the bedwetting alarm first, right? Because that's the standard way you treat bedwetting. If you've fixed everything else up but there's still bedwetting, a bedwetting alarm can help. And if that doesn't work within 3 months, then they can go on to oral tablets and stuff to help the bedwetting. And then with time, it usually resolves. There can be kids who've got actual bladder problems and kidney problems and stuff. So usually if the simple things don't work, then a urologist needs to get involved.
Jim, we've to say the last 2 years have been a challenging time is an understatement, but as a pediatric respiratory and sleep medicine physician, have you seen anything different in the last 2 years walking into your practice that has, changed?
The thing that I've seen different, Ron, and actually I got a text message from an ENT surgeon at the beginning of this year, sort of January, February, and his text message said, "Jim, did COVID-19 cure obstructive sleep apnea?"
Yeah.
And so what we've seen is a lack of referrals. Total sort of, it's gone by the by.
Yeah.
It's gone totally under the radar for the last 2 years. And I think that's because people have had bigger fish to fry.
Yeah.
And maybe also people reluctant to visit doctors' offices, go to, and a lot of things being done by remote learning, teachers not picking up as much about what's going on with the kids in the classes. Anyway, there's a whole range of reasons.
Yep.
And this podcast that you're doing, Ron, today, I'm hoping is going to raise awareness again.
Yes.
Of these issues and how important they are. And the sooner you treat them, the better. With sleep apnea, if you don't treat it by age 6, there was one study which showed that those kids were about 4 times more likely to be in the bottom 25% of the class in year 8, even if you treated them at age 6.
Wow. That's
so you got to get it when they're sort of 2, 3, 4 years old, ideally. It's but 100% chance of improvement and fixing and getting better even after age 6.
Yeah.
But the earlier you pick these things up, the better.
Jim, one last question, and thank you for today. We're all on a health journey as individuals. Putting aside your hat as a specialist, what do you think the biggest challenge is for an individual on their journey through life in this modern world?
I think it's anxiety. I think we look, the world has become a very uncertain place, even for children. I remember children used to be so carefree. I was, but children nowadays have worries as well, and it's just so sad. And parents have worries as well, and more worries than they used to, I think. I see the biggest challenge for our society as being anxiety and fear and terror in some ways, and I that's a bit philosophical, but that's my opinion. And I think if we can find ways within ourselves to be less anxious, have less anxiety feeds through to a more positive outlook on life. Positivity then helps everyone, not just yourself internally, but everyone around you. And that ripple effect is what we need. We need more positivity and less negativity.
Well, that's a great note to finish on, Jim. And I knew I was looking forward to speaking to you for quite some time, and now I'm pretty sure most of my listeners understand why this. So thank you so much for your time today, and thanks for sharing your knowledge and wisdom with us.
I have to thank you, and thank you, listeners, for their patience with my rambling. I go off on tangents too much. Sorry.
Perfect tangents for this program, Jim. Thank you so much.
Take it easy, Ron.
Well, I think you can now see why I said I was so looking forward to having Dr. Jim Papadopoulos on the podcast and sharing him with you. Last time I had the opportunity to speak to Jim like that was in a podcast I did with him about 8 or 9 years ago on the Good Doctors. It's so interesting to see where he has gone in these last 10 years. And wouldn't you love every single specialist to have that kind of approach, a very open-minded approach, a very holistic approach? Yes, he is a respiratory physician. Yes, he is a sleep medicine physician. But here he is looking at gut health. And of course, he is a pediatrician as well as that. So, of course, he would be looking at that. But I thought, in medicine now, over the last 10 years, it has been accepted that gut health is so critically important to our health. Hardly surprising, really, because you are what you eat. That saying's been around for a long time, and the truth of that saying has been around for even longer. You are literally what you eat. And, when you have a gut feeling, that's because the gut is now described as the second brain. So it's where so many neurotransmitters, those things that give us mood, like serotonin, and other neurotransmitters are actually produced. 80% of the body's serotonin produced in the gut. So it was great to talk to Jim and to get that perspective, that update, and to realise that there were so many, that was so often undiagnosed. And it's interesting to also see a practitioner, a specialist like that, who is clearly very patient-centred. And we use that expression a lot in our practice, and people ask, well, patient-centred, what's the alternative to a patient-centred practice? You would think that's the way every medical practice should function. Well, it's not the case. The other alternative is a symptom-based practice. If you, for example, have a snoring problem, then you go and see an ENT specialist, and that is their specialty, and so they will remove your adenoids or tonsils. And yes, your snoring may improve in the next few weeks or maybe even the next few months after that, but has it addressed the entire underlying cause? And it may not have. Or you might go in for an infection and you have an antibiotic, an inflammation, you get an anti-inflammatory, you feel depressed, you get an antidepressant, and so on. That is a very symptom-based approach. A practitioner-based approach is very much just focused on the practitioner's specialty and what their particular area of interest is. So it's great to for Jim to share that knowledge with us and for us to realise that there are many factors. And it's interesting to hear silent reflux being such a common and often undiagnosed problem in 40% of cases. I think the figure was something like that. And silent reflux is really something that, the name implies. You don't really know what's going on, but it is affecting your health. It may affect your health as a chronic cough, clearing your throat all the time, not sleeping well, feeling restless, not breathing as well as you might, a whole range of things, mood affected, your energy levels affected, and this can be about silent reflux. And we're going to be exploring that in one of our very soon-to-be released podcasts with laryngologist and speech pathologist Nikki Martin. So it was just great to have Jim on and for him to share his expertise and knowledge. I thought, well, I always like to ask practitioners, what do you think, on a personal level, what do you think the biggest challenge is? And Jim identified anxiety as that, and I think that is one of the features of the last 2 years that have become particularly pronounced, But I think we've done some other podcasts on digital nutrition with psychologist Jocelyn Brewer and Nia Ayal talking about the impact of digital world on our well-being. And we're going to be exploring anxiety, depression and trauma in the coming weeks and months. Anyway, we're going to have links to Jim's website, so that will be a resource that is well worth looking into if you need it. Hope this finds you well. Until next time, this is Dr. Ron Ehrlich. Be well. This podcast provides general information and discussion about medicine, health and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences and conclusions.